Shall we move on to baby A?
That is what I was hoping we would do. If I could, perhaps, before we go on. We will discuss in some detail. No, you carry on. We'll come to this, I'm sure.
We know that you've produced a number of reports with regard to baby A, haven't you, Dr. Evans?
Yes.
I just want to be clear about some of the conclusions which you've presented in them, before we look at his case. In the report of the 31st of May 2018, which is the one we've been looking at principally this morning.
Let me open that up, please.
Yes.
Right. Yes, I've got that.
Your conclusion in that is that the collapse was the result of inappropriate therapy within a minute or two before the deterioration.
Something like that, yes.
Well, it's not something like that. It's paragraph 38, Dr. Evans. In my opinion, baby A's demise was the result of his receiving inappropriate therapy prior to his collapse, probably within a minute or two prior to his deterioration.
Yes, his collapse. And the next sentence goes, his collapse is consistent with his receiving an air embolus. Yes.
Yes. You say that's consistent with an air embolus, and that is the rapidity of his collapse, is that correct?
Yes.
Very fast-acting indeed.
Yes.
Your view was that it was probably a bolus of air down the IV line.
Yes.
That is in paragraph 39.
Yes.
Now, you've explained how this is all based upon babies who were stable before collapse has happened.
Yes.
Just reminding ourselves where baby A is concerned, we know he was very preterm. 31 weeks and 2 days, wasn't he?
Yes.
And 1.6 kilos.
Yes.
So, low birth weight. And I think you acknowledge there are inherently problems that preterm babies face that can make them quite fragile.
Yes, I have heard that term. I don't think I've ever described a baby as being fragile. I think they are at increased risk. They are dependent. Fragile is too emotive for me as a term. It's not one I've ever used, I don't think, in relation to babies.
They are prone to complications, aren't they?
That's why we have neonatal units, yes.
That's right. They're prone to complication, aren't they?
Yes, yes.
Now, to look at what you say about baby A and his starting point in this case, it's a sad fact that he lived for barely 24 hours. That's right, isn't it?
Yes.
And so when we are considering the problems that he encountered, do you agree we need to keep in mind, sadly, how short the timescale is that we're working with?
Yes, yes.
And in a timescale like that, there isn't a great length of time for serious problems to make themselves obvious, is there?
The fact that he was as stable as he was, prior to his collapse, meant that he had survived the most perilous part of his life. And in other words, yes. So by the time that he was just prior to his collapse.
I wonder if I could just ask you, you've explained that. I wonder if I could respond to what you say about him being stable, because that's what I would like to ask you about, Dr. Evans. And I would ask you to help the jury with.
Yes.
When you were dealing with the question of how stable baby A was to start with, began by saying, I have said his condition was perfectly satisfactory. It's better to say he was stable.
Yes.
Just so the jury can unravel what that means. In your reports, you began by saying baby A was in a perfectly satisfactory condition, didn't you?
Mm-hmm.
You accept now, do you, that that's probably pitching it a little bit too high, isn't it?
No, I think, well, I don't want to get engaged in semantics here, but if you want to stick with perfectly satisfactory, I would say he was perfectly satisfactory for his position at the time. In other words, for a baby of his prematurity, aged 24 hours, his condition was satisfactory. If you want to make me look perfectly satisfactory, that's fine, but he was really good.
You agree, when he was born he needed rescue breaths before he was taken.
He did.
His rate of breathing was poor immediately after birth, and he needed inflation breaths, didn't he?
Yes.
He was all right after about 4 minutes.
Yes.
By 9 p.m. I can go to the notes if you need them, but by 9 p.m. on the 7th, there were pauses in his breathing when he wasn't being stimulated, yes?
Yes.
That's a potential problem, isn't it?
Irregular breathing patterns are very common in premature babies. It's something that one deals with on a regular basis, and it's not a cause for concern in a baby unit because they are on full monitoring.
He was on, in fact, CPAP, wasn't he? To prevent the airways from collapsing.
At the beginning he was, yes.
If we look at the clinical notes, please, they're at slide 84 and it's page 1062. It's slide 84 in the baby A profile.
1062.
1062.
I've got it.
It will appear in a moment, the ones in front of you. It's coming on. Thank you. If we just look at the top of that, please, Dr. Evans, just to give us an idea of where we are on the morning of the 8th of June 2015. Perhaps we can enlarge under where it says problems, Mr. Murphy.
All right. Preterm.
Can we just let everybody see it, Dr. Evans? If we just look at the top, this is the note from the clinical record saying problems, preterm, which is in itself a problem, potentially, isn't it?
Of course it is.
RDS, that's respiratory distress syndrome. That's a problem, potentially.
Yes.
Establishing feeds. That's a problem. Suspected sepsis at this point.
Yes.
And it's got maternal antiphospholipid syndrome. And we are going to hear more about that, and that's not something I'm focusing on in these questions. I'm not suggesting that's the issue here. But certainly at this point, there are legitimate concerns as to his progress, aren't there?
No, there are. These are, I'd rather call them issues rather than problems, but let's not get into semantics. This is what any competent junior doctor would list as the issues facing baby A at the time he arrived in the neonatal unit. In other words, we've to deal with the fact that he's preterm. We have got to deal with the fact that he might have breathing difficulties. We have to establish his feeds because his sucking-swallowing reflex isn't mature. He's at risk of suspected sepsis. And then there is this unusual condition of maternal antiphospholipid syndrome. By the way, I don't want to get involved with the antiphospholipid syndrome because I know there is a hematologist who knows far more about this. And this is outside of my expertise.
We're not raising any issue with that as it happens in any event, as I just said.
So therefore this is, for any baby of 31 weeks, the doctor would write these things down.
Now, if we just look at slide 32, it's a little bit before this. The clinical notes at slide 32, page 1061.
1061? Yes.
We will just wait for it to come up on the screens, Dr. Evans.
Yes. I'm relying on my own.
That's all right. If we scroll down, we can see an X-ray review.
Yes.
If we look at that just before 1 in the morning on the 8th of June, Dr. Brunton, and it says RDS type picture.
Yes.
So this isn't just something that's being written in the notes as a formula, or something any competent clinician would say. We have got here from an X-ray something which is certainly consistent with respiratory distress syndrome, haven't we? On the X-ray.
I have seen the X-ray. I have seen the report. There's nothing, it's not too bad actually.
It's the sort of thing which might lead to some difficulty with breathing though, isn't it? RDS.
This is why we put babies on CPAP.
But, in terms of where you're saying he's stable and whatever, just look at the various factors.
No, this is at
0:45 in the morning of the 8th of June.
Yes, so he was born at 8:30 p.m. Yes, 4 hours old. He's 4 hours old. This is the X-ray at 4 hours. My comment regarding stable relates to him at 23 hours of age.
We know we've got blood gas readings up to as far as they go, and they are tile or slide 29, page 1125. So let's have a look at that, please.
1125.
Slide 29 for those of us on the iPads.
Yes.
Just enlarge the top half so that we can see that, Mr. Murphy. If we look down there, this is moving forwards now. We've had the X-ray just after midnight on the 8th. If we look at 6:37, look across to lactate. That's on the high side, isn't it?
2.6. Pretty marginal. Again, from a clinical point of view, it's very important to look at the whole picture. Therefore, if you have a whole load of blood tests, 1 or 2 might be slightly outside, accepted, the norm. 2.6. So it's over 2.
Yes, and at, what is that, 2:30? It's risen a bit more to 2.7, hasn't it?
It's the same.
Would it not bother you if you were looking after a baby to see the lactate increasing above the recommended range?
Not particularly. Well, it's not. Let's look at the whole Let's look at the whole results. Okay, for 14-13, I think they are. You've got a pH of 7.37, spot on normal. You've got PCO2 of 5.15, spot on normal. It's a capillary gas, so you can't interpret the oxygen level. It's 4.66, but you can't interpret that.
Is a little low, isn't it?
No, you cannot interpret that. Okay, you cannot interpret.
Why is that one not interpreted? It's low, isn't it?
No, it's not. It's a capillary sample. You can't interpret it. All right? Listen. Then you've got a bicarbonate of 22.3, which is normal, and a base deficit of 2.5, which is, less than 5, which is fine. So therefore you've got this blood picture, and you have a glucose, by the way, of 5.5, which is, again, normal. Therefore you've got 1, 2, 3, 4. You've got 5 normal tests, and one that is on the margins of being slightly up a bit.
Just so the jury follow.
Just a minute. And then in addition, and I'm sure we'll come to this, in addition to that, even more usefully I think, we've got this constant monitoring, heart rate, oxygen saturation, and they are also normal. And, as Dr. Bohin said earlier, he's handling well.
We are going to go there. Don't worry, Dr. Evans.
We'll go there.
Can I just check? With oxygen, the standard range is 7.5 to 10. For blood gas, isn't it?
For an arterial sample, you would like it to be more than 7.
More than 7.
More than 7. 8, 9.
10?
11. 12.
Right. You say you don't really count this because it is from a heel prick.
Yes.
In any view, the oxygen is dropping from what it was at 637, isn't it?
As I have said, I am not going to interpret an oxygen value from a capillary sample.
Okay.
Let me say that, for all babies, for all times, I'm not going to do it.
We don't have any readings, do we, as we get to the period we are most interested in? In terms of, sadly, the deterioration at about 8 o'clock?
We do, actually.
Do we have any on this chart?
No.
You tell us where the readings are.
On the neonatal...
Are you talking about the respirations and heart rate and things like that?
Yes.
I'm going to that. I'm talking about blood gas readings, Dr. Evans.
Sticking a needle into a baby's heel hurts, so you can't do it every few minutes or so. So therefore, it's done quite frequently in this particular case, which is fine. That's not a criticism. If I saw these gases at 1400 hours, 2 p.m., and my baby at this time was in air, I would not be rushing to stick needles into that baby any time soon unless there was a change in his condition. That is what we call good clinical practice.
How long can you leave?
You don't stick needles in babies unless you have to, or unless there's a very good reason for it.
How long would you leave it for?
Until, or unless something happens that makes you concerned that there's something the matter with the baby.
Let's take a look at 1123, please, which is the observations chart.
1123.
Provided on that...
That's the one I was talking about.
We will come to that in a moment. That is slide 28 I've got down, but they appear in more places than one. So slide 28, if we could put that on, please. We can see... Let's just increase the size in the yellow sections, please, Mr. Murphy. We're familiar roughly with what we're dealing with here now. Yes, you made reference to what Dr. Bohin said before lunchtime. She said it was stable and not escalating. That's her words, not escalating.
Correct.
The respirations on the chart, what we see.
Let's go through them from the top down. That's the easiest way.
I think it would be better if you're actually asked a question and you answer the question rather than just speaking to the document.
I would be grateful for that. Let me direct the question, Dr. Evans, to assist with what we're looking at. We're talking about stability, right? And you made reference to Dr. Bohin. I made note of what she said, which was extremely stable, not escalating. Now, if you look at the respirations, first of all, please. Those are not extremely stable, are they?
I disagree. Because his respiratory rate is in the yellow bit, it's higher than the accepted normal range. It's 70 plus rather than 60, 50 or 60. But if you have any feature that is outside the normal range, you need to find out what the probable cause for this is. And you need, as in every case, you need to interpret one individual criteria, marker, in relation to everything else. So what we've got here, if you look at, yes, So if you look at the respirations there, right, from the beginning. So in the first third, they are all in the yellow, if you put it that way. And somebody has written down there, unsettled, I think. And then it falls to about 60. And then from, I don't know, let's see, 11 noon, say, from noon, it toodles along at about 70.
Well, it's escalating in the afternoon, isn't it?
It's higher than it was, but there's a perfectly good explanation for that.
It's all stable. It's all in the yellow patch, isn't it?
Yes.
Why is it yellow, that bit?
There's a perfectly good reason for that.
Well, what is it?
Well, the doctors have been fiddling around with him, putting umbilical catheters in.
Why is that section yellow? I wasn't clear. Why is it yellow?
I think he was giving you a perfectly good explanation.
I apologize.
He was giving you the explanation for it, I think. I'm not the witness.
If you go through the medical notes, medical charts at this time, you will find that the doctors are doing what they can to, make sure this baby stayed stable. So they have been putting umbilical catheters in. It's ended up in the wrong place. Nobody's fault. It happens. Then around 6 o'clock, from what Dr. Harkness said, they put an IV line in, a long line in. Sticking a needle in anybody's vein hurts. It's uncomfortable. You're handling the baby. Therefore, all of this will make anybody, not just a little baby, a bit unsettled, so therefore his respiratory rate goes up. So what's important in clinical practice is that if you've got a feature that's outside the normal range, that you find an explanation for it. And there is an explanation for it. This baby was being handled, quite correctly by the way, but it meant that he was being fiddled around with because of the difficulties with cannulas, and then getting the IV line in. So there we are. So that in itself is an explanation, but even more important, all the other markers are normal or stable.
Now, do you agree, first of all, the respirations are at least elevated for almost the whole of that period, Dr. Evans?
Yes, they are.
Do you agree that they move down, they move up?
Yes, they are.
So the first thing is you agree, as we look at it, that is not steady. It's not at one level, is it?
It's variable.
Do you agree, as we look at it in the afternoon, it is escalating? Yes or no? Tell us if you don't. We can see it. What do you say?
It's gone up. It's moving between 75 and 80.
There isn't a lot of chart left, is there?
It's not escalating.
Do you agree that when it goes onto the yellow, that's done because it draws attention to something that might be a problem?
In isolation, I don't think you can make a diagnosis from an isolation. I don't know what we're getting at, but you've got an isolated increased respiratory rate in a baby who is preterm, and everything else is nice and normal.
Do you agree that his respiration goes up? You might expect ordinarily heart rate to go up together with it.
Yes.
His heart rate doesn't go up, does it?
No.
That's odd, isn't it?
No.
You have just said you would expect it to go up, and now you are saying it is not odd.
I would expect the heart rate to go up if, let's rephrase that. If his heart rate had gone up as well, then I would be concerned about the baby. I would be concerned that he was then not stable. But in fact, his heart rate is about as normal as it can be. So therefore, heart rate is a very, very good marker of well-being in a little babe. Therefore, we have got this increased respiratory rate in isolation. Am I worried about it? No. Why am I not worried about it? Because he was in a neonatal unit with experienced nurses and doctors to look after him. And on top of that, he's not even requiring additional oxygen. And that, for a prem baby, coming up to 24 hours of age, the fact he's able to breathe without additional oxygen and his saturations look at 97, 98, 99%, that's about as good as it gets, okay? So therefore his respiratory rate is above the normal range, but this little fellow is in air with normal saturations and a normal heart rate and a normal temperature. So, great.
Do you say it was good that he hadn't had, I don't mean good for him, but was it clinically acceptable that he hadn't had fluids for at least 4 hours and maybe longer by the time?
It's not good. It's not good.
Is it acceptable?
Well, it happens. This happens in neonatal units. This is the way of the world. And I think I discussed this morning. Nobody would want a baby to go without fluids for 4 hours. Did it make a difference in his case? As I discussed this morning, no. Why do I say that? Easy. If he was experiencing fluid loss. Then, as we know from patients who are admitted with fluid loss, the heart rate goes up. His heart rate didn't go up. So it's unfortunate, but it is not something that it wouldn't be. My word, we are all going to get COVID in a minute. Where are we? I'm getting distracted here.
Let me help you. What I would like you to help us with is this, Dr. Evans. Is there a possibility that there's a problem for him not to have received the fluids he was meant to have received for a period of, and the blood sugar, for a period of 4 hours? Is that a potential problem? That's what we need to know.
His blood sugar, the most recent blood sugar they took was 5.5, which is great, which is fine. That's fine.
That was about 6 hours before the collapse, wasn't it?
Yes.
Yes.
A blood sugar. Sorry.
Just to assist you, Dr. Evans.
Excuse me. I'm being distracted by loads of people coughing. Just a minute. So, he lost 4 hours worth of fluid, which I think he was on 4.15 milliliters an hour. So he missed out on a theoretical 16 milliliters of fluid, now of 10% dextrose. And 16 milliliters of 10% dextrose contains 1.6 grams of glucose. And 1.6 grams of glucose contains 6 calories. So a baby who has lost out on 6 calories is not going to drop a glucose value from 5.5 to a level where he crashes. This baby did not have a little twitch or anything like that. He crashed to the extent he died. Sorry. Let me finish this bit. So therefore it's unfortunate that he did not receive IV fluids for 4 hours. He did receive some oral fluid, by the way, 1 or 2 milliliters, which is better than nothing.
That's no substitute for failing to get the IV fluids, is it?
No, it's unfortunate, but in this particular case, it did not make a clinical difference. And that's the important point I need to impress.
Going without fluid for the 4 hours is capable of causing dehydration. Do you agree or disagree?
Of course it does.
And also, going without the glucose that he was meant to receive for 4 hours is capable of leading to or triggering hypoglycemia, isn't it?
Yes.
In a child which we know is now tachypneic, which is breathing too fast.
Yes.
But you don't see any of that as being a potential problem. Is that your evidence?
It's not so much that I don't see it as a potential problem. From the records I have seen, it was not a potential problem.
We don't know that, do we, Dr. Evans?
Yes, we do, actually. Yes, we do. This baby was in air, his saturations were 99%, his heart rate was nice and steady at 130, 140, and his temperature was fine. So we have got loads of markers here of a stable baby. And I heard Dr. Harkness say he was absolutely devastated by the baby collapsing because, and Dr. Jayaram the same, this was a baby who was stable prior to his collapse. Their words, not mine. Their words, not mine. But I'm just looking at these records and, yes, the respiratory rate is tachypneic. Yes.
I'm going to avoid repeating questions I ask, to say where we disagree. That would be clear from the questions I'm asking, and I'm going to move on so that we can get through the evidence. Do you accept there is a potential risk of arrhythmia from the position of the long line? In other words, is there a potential risk that it could have been sited too close to the heart and created some sort of problem?
Not in this case, no.
Do you see that there's any obvious link in the relationship in time between long line insertion and then fluid running through the long line and then collapse?
No. I'm not sure that question what you mean. Long lines are routinely used. Fluids running through a long line does not cause a baby to collapse.
Do you recognize, or do you accept, there's any risk involved in leaving a long line in place without fluid running through it for up to 2 hours?
No, there would be fluid in it.
Running through it, I asked.
Not running through it. Right. If there was... Right.
Can I ask the question, and then you can by all means expand upon it if you need to, Dr. Evans. But what I asked was, is there any risk caused by leaving a long line in place without fluid running through it?
There's a risk of the long line clotting.
Tamponade. You have explained that's where fluid gets into the gap between the heart tissue and the external sac of the heart, the pericardium.
Correct.
When you made the report that you have been looking at, and you were dealing with the question of tamponade, and you deal with this at paragraph 36 of that report, page 752. What you say, Dr. Evans, is that cardiac tamponade is a complication of long lines. It typically occurs in a baby where the line has been in place for some time, probably 24 hours or more. This would not occur within minutes of insertion of a long line. Just to be quite clear, did you think it had only been in place for minutes when you said that?
Well, I'm not quite sure, but it didn't look within a couple of hours anyway.
It could occur, you say it couldn't occur within a couple of hours. Couldn't.
No. Let's forget about tamponade. If there was tamponade there, it would be present on post-mortem.
I just wanted to see why you say minutes. Infection. Do you accept there are potential...
I just want to get a note there. Thank you. Carry on.
Sorry, my lord.
No, it's fine.
Do you accept that there are potential signs of infection or developing infection from what we can see in the observations and the blood gas and the picture presented by baby A?
No.
You don't regard high respiration as a possible indicator of it?
Well, again, two things. It's an isolated sign, and secondly, there was no evidence of infection on post-mortem.
It's entirely possible, in a fast-developing infection in a small child, for it to develop and leave little by way of pathological signs. It is, isn't it?
This is simply wrong, okay? This is simply wrong. What you're suggesting is that a baby would have an infection that was so spectacularly rapid that the baby would die, despite having normal heart rate and all these other normal things, and where a pathologist found no evidence of infection on post-mortem. I mean, that's ridiculous.
Okay. Can I just ask you to confirm this? In terms of blood sugar, can I ask you to confirm this? At times of blood sugar, in terms of blood sugar at the time of the collapse, are you able to assist us with what the reading was at that point?
No. Perhaps you can remind me, but
Well, we've seen there's a chart which has the blood sugar readings until we get to 2:15 that afternoon.
Yes.
After that point, baby A received no fluid and no more blood sugar, did he?
We've been through that.
Yes. I'm sorry to delay you, Dr. Evans, but I wonder if you can help me with this. After that time, he received no fluid and no blood sugar, did he?
He received no fluid for 4 hours.
And no blood sugar?
No, he didn't have a blood sugar.
And we don't know what his blood sugar reading is at the time of his collapse, do we?
No.
Because no one has got it. So can you discount in those circumstances a deterioration linked to hypoglycemia?
Yes, I can.
Just so we can be clear, why do you say that?
Because hypoglycemia is pretty common in small babies, and they can be a bit jittery, they may have little fits. They don't just stop breathing on you. Well, because they don't. But if they did, they would respond pretty promptly to resuscitation. So yes. So, babies, yes. So there we are. So hypoglycemia is not a factor in causing this little baby's death.
Just so it's quite clear where we are, although you've dealt with this. The suggestion I make to you, Dr. Evans, is, from the available signs there, he was not stable, and he was not in a good condition at the time that he collapsed. You disagree with that?
I do. I heard the practicing doctor say yesterday. Earlier, they all used the word stable. Dr. Jairam did. Dr. Harkness did. I'm not sure about the others. But yes, they said he was stable. Looking at his markers here, apart from the tachypnea, we have markers of a stable baby, who, but for having an air embolus, would have survived.
That is what the practicing doctors have said. Do you accept everything they say?
Well, that's their opinion.
Did you apply an independent mind to what they say?
I have been pretty independently minded all my life.
I just wonder, you said about people not spreading news about the mistakes we make. Are you looking at this as critically at the people who've given care as you are at other elements?
Yes, I have actually. Yes.
Right.
Yes, I'm pretty independently minded.
Can I ask one other thing about signs or indications we have with baby A just before I move on? And if it's something you can or you can't deal with, please say, Dr. Evans. A finding in the post-mortem which you're familiar with, Dr. Shukla. I don't mean you have it immediately to your fingertips. Do you want to remind yourself from the statement? It's a finding of congestion and hemorrhage at the time of the post-mortem.
Say that again. Have you got his...
It's page 724 in the statements.
Is this one of the J numbers?
It's an I number.
I don't think I've got that. I have seen the report, but I haven't. Last night. Tell me what you want me to answer, and I'll see... on the whole, if it's a pathology report, I'm more than happy to defer to the pathologist, okay?
I don't expect to raise something on the hoof with you like that, Dr. Evans. I don't mean that to be rude to you. If it's not something which you're turning your mind to, we can deal with it in due course if we need to. I'll deal with it that way, rather than ask you to form opinions as we go along.
If it's a pathology report, I would defer to a pathologist, and I know there is a pathologist in this trial.
There is.